Welcome. We're going to go ahead and get started. I have some opening remarks, and I'll turn it over to my Vice Chair, Elizabeth, and then we'll open up to the committee members to make some opening remarks, and then I'll take you through our process for today, and then we'll get into the meat of our meeting. I'm Jeff Baylett, Dr. Jeff Baylett. I'm the chair of the PTAC. I want to welcome everyone for joining us today, and there's a number of folks on the phone as well. This is our April meeting for the Physician-Focused Payment Model Technical Advisory Committee, or PTAC. We're delighted to have you all here. As you know, this is our first meeting that will include deliberations and voting on Medicare physician-focused payment models submitted by members of the public. We would like to thank you all for your interest in today's meeting. In particular, thank you to the stakeholders that have submitted models, especially those that are here today. Your hard work and dedication to payment reform is truly appreciated. We've spent the past year establishing our processes and procedures for receiving and reviewing physician-focused payment models. We want to stress that our process is shaped by the input from stakeholders. Although we will begin deliberating and voting on proposals today, we are committed to listening to your feedback and evaluating our processes accordingly. We value your comments at every level, especially as they relate to our receipt and review of proposals. We also want to remind you that the PTAC is a committee of 11 members, not a committee of 1. To the extent that questions may arise in the process as we consider your proposal, please reach out to staff through the PTAC.gov mailbox. The staff will work with me as chair and with Elizabeth as vice chair to answer your questions. In the interest of consistency in responding to submitters and members of the public, please reach out to us through this process that we have in place. Today, we will be deliberating on one proposal, and tomorrow we will deliberate on 2 proposals. Discussion of each proposal will begin with presentations from our preliminary review teams, or PRTs. The PRT reports are reports from 3 PTAC members to the full PTAC and do not represent the consensus or position of the PTAC. PTAC reports are not binding. PTAC may reach different conclusions and a different recommendation from that contained in the PRT report. And finally, the PRT report is not a report to the Secretary of Health and Human Services. PTAC will write a new report that reflects deliberations and decisions of the full PTAC, which will then be sent to the Secretary. Following the PRT presentation and some initial questions from PTAC members, the committee looks forward to hearing comments from both the proposal submitter and the public. The committee will then deliberate and vote on recommendations to the Secretary of Health and Human Services. Our job is to provide the best possible recommendations to the Secretary, and we are excited to begin this process. So I want to turn it over to Elizabeth for additional comments.
Thank you, Jeff. I will be brief. I also wanted to thank everyone for being here. Thank you for your interest and for the proposals that we have received and just the commitment I think that we all share to the promise of payment reform, which is better care at lower cost. So that's why we're all here. And I want to reiterate sort of our commitment to a transparent and inclusive process. We hope to get to yes. We would like to include as many models as is appropriate in the CMS portfolio, and we are looking for ideas from the field. That is why we are here, to find those good ideas and to help create opportunities to participate. So we have a committed group, and as Jeff said, we have spent about a year coming up with a process that we hope is fair and open, and we invite your feedback on the process and on the content. So thank you again for being here, and we'll turn it up to the committee.
Any of our committee members have any opening remarks they'd like to make before we get started? All right. So we have an 8-step process in deliberating and voting today. We will start with a summary of the deliberating and voting process for the public. We will disclose the potential conflicts of interest and threats to impartiality among our committee members. Then we will have a presentation by the physician or by the proposal review team, and that will go to, obviously, to the full PTAC. Statements of the submitters. We have the submitters present. Also public comments. We have some people who are signed up to make public comments. And then the committee will start deliberating and voting on each criteria, and the committee will ultimately end voting on the recommendation, the final recommendation to the Secretary. And then we will work with staff today to try and lay out the framework to capture the deliberation and the recommendation. So unless there are other questions from the committee, we're going to go ahead and start our process by introducing ourselves, and included in that introduction any areas of conflict or new potential areas of impartiality. We, as each individual committee member, will do that now and then proceed. So I'll start with myself, Jeff Baylett. I'm an otolaryngologist. When I was appointed to the PTAC, I was the president of Aurora Healthcare Medical Group in Wisconsin. Since January, I have taken the position as Executive Vice President of Healthcare Quality and Affordability with Blue Shield of California. That is a new disclosure. The committee is aware, the Secretary is aware, but I feel the need to disclose that today. I'll turn it over to Elizabeth.
Thank you. Elizabeth Mitchell. I'm the President and CEO of the Network for Regional Healthcare Improvement, and I have nothing to disclose. Tim?
Yeah.
Tim Ferris. I'm a primary care physician, internist, and pediatrician at Mass General Hospital in Boston and Partners Healthcare in Boston, and I have nothing to disclose with regard to this proposal.
Hi, Kavita Patel. I'm an internist at Hopkins and Johns Hopkins, and also a fellow at the Brookings Institution. And I disclosed on our disclosure form and just verbally that I have heard the proposal that's being discussed presented at meetings in the past.
I'm Bob Berenson. I'm a fellow at the Urban Institute, a former practicing general internist, and I have nothing to disclose regarding the proposal.
Paul Casal, a cardiologist. I lead the ACO at New York Presbyterian, Columbia Weill Cornell, and I have no disclosures.
I'm Harold Miller. I'm the President and CEO of the Center for Healthcare Quality and Payment Reform. With respect to the proposal that we're hearing from today, I know Dr. Kaczynski, who is the developer of the proposal, professionally, not personally. I know him because several years ago, someone told me that there was a physician out in Illinois who actually had an alternative payment model with a private health plan, and that was such an unusual thing to hear about at that point that I went looking to find out who that was and came across Dr. Kaczynski. And I have invited him to come and speak at some conferences about what he is doing. But I have had no involvement in the proposal that he is presenting today in any fashion, nor will I benefit from it in any way. I've also been involved with helping a number of other medical specialty societies develop alternative payment models, but there is no conflict that I can see between any of that work and the proposal that is here today. So I've told my colleagues that I don't believe that I have any conflict of interest or lack of impartiality with respect to this.
My name is Lynn Nichols. I'm a health economist from George Mason University, and I have no conflicts with respect to the proposal today.
My name is Grace Terrell. I'm a practicing general internist at Cornerstone Healthcare, a multi-specialty medical practice. I'm on the board of CHESS, which is a population health management company, and I've just transitioned to the role of Chief Executive Officer of Envision Genomics, which is a biotechnology company. I have no conflicts to disclose today.
I'm Bruce Steinwald. I'm an independent consultant and Medicare and healthcare financing issues here in Washington, D.C. I have nothing to disclose on this proposal.
Thank you. And we're going to go ahead and start with Dr. Paul Cassell, who will present the PRT report on Project Sonar.
Great. Thank you, Jeff. Before I start with the actual presentation, just to provide some overview. So the PRTs, has already been outlined, are composed of 3 members of the committee, and a lead is identified within that team. The proposal overview and summary of the PRT review are the next steps in our presentation, followed by key issues identified by the PRT, and then the initial evaluation from the PRT is done using the Secretary's criteria. So as I mentioned, the PTAC chair and vice chair assign 2 to 3 PTAC members, including at least 1 physician, to each complete proposal to serve as the PRT. And again, 1 PRT member is selected to serve as the lead. The PRT identifies additional information needed from the submitter and determines to what extent any additional resources and/or analyses are needed for the review. ASPE staff and contractors support the PRT in obtaining these additional materials. After reviewing the proposal, the additional materials gathered, and public comments received, the PRT prepares a report of its findings to the full PTAC. The report is posted to the PTAC website at least 2 weeks prior to public deliberation by the full committee. As already identified and mentioned by Jeff, the PRT report is not binding on PTAC. PTAC may reach different conclusions and a different recommendation from that contained in the PRT report. So with that background, I'm going to go through our PRT review. So just a brief overview on the proposal. So the Project Sonar proposal describes their model as a specialty-based intensive medical home intended to address quote-unquote high beta chronic diseases, those associated with high cost, high risk, and high variability in outcome and cost. And in this model, they presented information particularly around Crohn's disease. And just again, brief summary of the intervention. The model uses evidence-based guidelines, including clinical decision support tools embedded in the electronic medical record to direct care. Risk assessment uses the American Gastroenterology Association Crohn's Disease Care Pathway. An enrollment visit with a nurse care manager initiates the model and subsequent communication with the care manager through a web and mobile-based platform or by phone calls. Patients are quote-unquote pinged at least once per month. This can be done via smartphone or other device of their choice to submit self-assessment data based on the Crohn's Disease Activity Index. And then the care manager, nurse care manager contacts non-responders by phone to administer the questionnaire, again, for those who don't respond in other manners. The patients receive follow-up from the care manager if their data falls outside the standards. If indicated, the nurse care manager communicates with the specialist and arranges an office visit or phone call. And use of the Sonar MD platform, a cloud-based care management platform, which utilizes proprietary chronic care management algorithms, the clinical decision support tools, and predictive analytics. In regards to payment, CMS would provide the alternative payment model entity additional payments for remote patient monitoring services for each beneficiary enrolled. So there's a payment for the enrollment visit, and then a per beneficiary per month payment. The APM entity would also be eligible for shared savings and losses based on retrospective reconciliation against a risk-adjusted target price. There are stop-loss provisions and outlier protections also included. The APM entity would distribute shared savings to individual physicians based on the number of patients followed, ping response rate, and risk-adjusted cost of care. So the initial review by PRT, the results are here, and I'm going to walk through each one of these next. And then just to highlight some of the key issues identified by the PRT, the proposal indicates that the model could apply broadly to diseases with high cost, high risk, and high variability in outcome and cost. But the evidence in the proposal only relates to inflammatory bowel disease, and in particular Crohn's disease. The model makes innovative use of technology to monitor inflammatory bowel disease patients to prevent unnecessary emergency room visits and hospitalizations. But the platform chronic care management algorithms and clinical decision support tools and predictive analytics are proprietary. A care management fee rather than a new payment model may be sufficient to achieve the care delivery changes described in this model. The experience of the model in general is in a younger commercial population, and it may not necessarily translate to the elderly Medicare population. And then finally, the proposal lacks comprehensive quality measures tied to payment. So with that as an overview, I'll go into each of the criterion and our assessment. So criterion 1, which is the scope of the proposed payment model, which is a high priority criteria. The proposal indicates that the model could apply broadly to high beta chronic diseases, but again, details are limited to the submitter's experience with IBD, specifically Crohn's disease. And so within the scope, in 2015, the data that we reviewed, approximately 0.48% of the Medicare fee-for-service population had inflammatory bowel disease, and this accounted for 1.25% of fee-for-service spending. And while 20 large GI practices have implemented the Sonar MD platform, practice feasibility, level of interest, and potential impact based on practice size and specialty are not included. And thus, it's hard to conclude how the model would offer opportunities for others to participate in the alternative payment model. Entities to include, how the, in a new way, proposed model would include, in a new way, because of the lack of information on additional disease areas, it's not clear how this model, again, would offer opportunities for others to participate. Under quality and cost, quality reporting would be based upon MIPS and Project Sonar derived measures, but the examples for IBD seem fairly limited. The proposed quality reporting measures are primarily based upon laboratory values and patient response rates. More metrics tied to overall improvement in care and patient satisfaction, as well as patient-reported measures, are needed. We also discussed in our review that the submitters were in the process of piloting the use of hospital anxiety and depression score and the CDC Healthy Day core measures, although this was in the pilot stage. Medicare beneficiaries with IBD, as I already mentioned, account for a small percentage of Medicare fee-for-service spending. Younger patients with IBD often have more active disease than, or may have more active disease than the older patients, so impact on emergency room and hospital utilization rates seen in the commercial population may not necessarily translate to the Medicare beneficiaries. And some of the, in our discussions, we also noted that some of the cost-saving measures that were suggested by the submitter included improved medication adherence and moving infusion services from hospital outpatient to non-facility office settings, but there was no data provided in support of these statements. Under criterion 3, or the payment methodology, again, another high priority area, the proposal does not address how to manage payment when there are multiple chronic conditions and providers. A care management fee rather than a new payment model may be sufficient to achieve the care delivery changes described in this model. In the Medicare population, IBT patients may have fewer exacerbations of the disease compared to a commercial population. Thus, there may be limited variation in utilization. Thus, opportunities for shared savings or losses may be small. And individual providers do not receive shared savings based on patient satisfaction or care outcome measures. Criterion 4, value over volume. It was not obvious if office staffing arrangements might need to change in order to accommodate Project Sonar, particularly in different practice settings. The proposal does not sufficiently describe the mechanisms that would drive physicians to change behavior. So it's unclear whether the presence of a care management fee is critical to any behavior change, or if it's more important for the patient pings to drive behavior change. The role, if any, of non-financial incentives is unclear. And while opportunities for shared savings and losses could be seen as one way to promote value over volume, the specific financial incentives in this model do not seem sufficiently structured to do so. And I apologize, I should have started each criteria by saying how the PRT voted, so I know it's up there, but I should say that the initial review on the first 4 criterion was does not meet criterion. On criterion 5, the PRT felt it did meet, the model did meet criterion. The model allows patients to communicate with the care manager via a web and mobile-based platform as well as through phone calls. The proposal indicates that small practices that may not have the volume to support a care management could engage in a shared service model. However, the proprietary nature of the Sonar MD platform, again, as it relates to chronic care management algorithms, CDS tools, and predictive analytics, may be an obstacle for others to participate in the model. On criterion 6, again, the PRT concluded that it meets criterion. Metrics such as cost of care, including ER utilization and hospitalization rates, can be tracked through the claims data, as well as the ping response rates, which can be tracked through the Sonar MD platform. The proposal provided results from the ongoing pilot of the model with commercial payers. The quality measures proposed can be evaluated, but are felt not to be comprehensive. In terms of integration and care coordination, the PRT felt that the model did not, the proposal does not meet the criterion. The Sonar MD platform enables the care manager to monitor a practice's patients and initiate physician involvement when necessary, but the involvement appears to be largely limited to the specialist. The model seems to have little integration with other clinicians, particularly primary care providers. Primary care providers could potentially access patient information from the Sonar MD platform, but it seems that they are more likely to receive notes via fax. And with the exception of the care manager, it is unclear how the frontline office and nursing staff would change in order to support this model. Criterion 8 on patient choice, the PRT concluded that it does not meet criterion. Patients make the decision to enroll and can interact with the care management via a web and mobile-based platform. However, the experience of Project Sonar in the Medicare population is limited. It's a patient group and previously, traditionally, has been less inclined to use mobile apps as a primary source of contact. And the potential technology gap would be addressed by providing traditional phone call care management, but it's unclear whether phone calls are for the same benefits as the web or mobile-based communication. In terms of patient safety, the PRT concluded that it meets criteria. The model activities that would likely improve patient safety include the remote monitoring of patients to identify clinical deterioration and initiate intervention early, reducing the need for ER visits and hospitalizations, and the risk assessment to help determine the appropriate frequency with which patients should be pinged. And then finally, criteria 10, health information technology. The PRT felt it did not meet criterion. The model, recognizing that the model makes innovative use of technology to monitor inflammatory bowel disease patients to prevent unnecessary ER visits and hospitalizations. But the concern is that the platform and clinical algorithms are proprietary. There has been a positive patient experience with the use of this technology in the commercial population, but again, unclear how this would translate to the older Medicare patients. And the model still seems to face significant interoperability challenges. In order to access notes from the specialists, primary care physicians would need to access a separate system or receive faxes. And that's the end of the report.
Thank you, Paul. I'd like to open it up to the committee to ask any clarifying questions of Paul or the PRT teammates. Grace?
I have several questions. One is you talked about the potential for the age to not be as relevant in an older population, but Crohn's disease has a bimodal distribution with a second peak between the ages of 50 and 80. Was there any evaluation on the part of the PRT to understand the prevalence of disease in the older population as it relates to that?
Yeah, go ahead, I'll let you.
I'll start. Yeah. We actually knew that as well, and so we asked our data team, our contractors who are able to rapidly pull from the Medicare claims files data on that to then quantify patients, total number of Medicare beneficiaries looking back over the last 4 years, just to see if there was anything different year to year, but there was not. And look at beneficiaries with inflammatory bowel disease, of which there were approximately 136,000 on average each year. Beneficiaries with Crohn's disease, of which there were about 70,000, and beneficiaries with ulcerative colitis, of which there were about 65 to 70,000, but again, over 4 years from kind of year to year, thereby looking at kind of that bimodal distribution, and that's where we came up with kind of understanding what the prevalence would be in the Medicare population. So we did tease that out and asked our data partners to look at that.
A couple of more questions, clarifying questions. So the idea of proprietary information has come up in more than just this proposal. And in one of the other PRTs, we were told that that Medicare does sometimes permit technology that is proprietary to have a code or whatever and be used. Was there any exploration with CMS or any of the folks that were advising us with respect to this particular point?
We did not explore it with CMS. We just asked the submitters again to understand, the proprietary nature of Sonar. Is the expectation that it will remain proprietary? And an answer to that was that the expectation is that it will continue to be proprietary. But we did not explore it with CMS in terms of their willingness to accept that as part of the model.
Final question. Oh, go ahead.
I'll just add, and we knew that, again, the technology, and we'll hear from the submitters, we knew the technology had these clinical algorithms, kind of the pings, the response rates, and that platform, as well as the analytics. The submitters did comment that the clinical algorithms that underlie the proprietary technology are public, or at least that is evidence-based kind of disease recommendations. But again, looking at the total technology and really the analytics and that kind of proprietary pings and some of those things,
okay,
that was really what was felt to be part of what was offering this larger care management that the nurse care manager would draw from. And so we did not engage with CMS because that was something that was very unique to just this aspect.
All right, final question. There was a comment made about the lack of integration with primary care providers. That presupposes that there ought to be. And although many of us believe that, and that's been the party line, there's also a lot of work that's been done around the concept of, for certain individuals with complex chronic disease, that the medical home concept would be better served by specialists. So how much work did you all do in understanding the issues around those tensions right now in the concept of chronic disease management?
So I'll start, and then you can add on. Certainly, as a specialist, I certainly understand that dynamic. And but again, as was pointed out, one of the concerns is that the model has been primarily in a younger population, in which this might be their principal diagnosis, as opposed to Medicare. When we looked at the data, whether we looked at the tables that go up to 10 chronic care conditions, there were quite a few of the Medicare inflammatory bowel disease patients who had multiple chronic conditions. And so that it was going to be inherent, even if the gastroenterologists were going to be taking primary care of the inflammatory bowel disease portion, that there would be a seamless information exchange. And in the model that was presented, it did not. We had a lot of concerns around that information flow back and forth, even if the gastroenterologists were taking primary responsibility for the inflammatory bowel disease.
And we, just to also kind of, I think you were also asking, Grace, kind of what steps we took to understand kind of what was unique about the kind of conditions suggested and the role of a specialist in terms of a medical home, or just even a specialist care. So we had our literature review, and then the three of us tried to understand, even kind of at a deeper level with that initial literature review, what really would be kind of the state of evidence. And we also drew the same conclusion that, in fact, this is a condition that largely is managed by the specialist, but even information being transmitted around medication changes or things that might have an impact because of other comorbidities, that was where there was a functional limitation, because those communications were generally going to be done by fax or by the more conventional communication that exists today. So that was really more of a comment about not necessarily that the primary care physician has to drive it, but there's still a coordination function, and that is obviously being done by the current specialists, but it's still kind of outside that really unique care management platform that was really being offered as the core of the proposal.
And just to add on one other thing, and again, if you looked at the data, I believe about a third of the patients had coronary artery disease, at least half have hypertension, the usual things. And so those obviously need to be managed as well, so that coordination is going to be important for this patient population.
Yeah, I'll be asking for any proposal related to a condition, the following kind of a question. Does the model itself, given the fact that Crohn's disease is often misdiagnosed, and irritable bowel is sometimes called Crohn's disease, colitis, when it's limited to the large bowel, can be mistaken for ulcerative colitis, celiac disease, et cetera, is there any, and when we're giving extra money and especially shared savings, shared risk approaches, is there anything in the proposal that assures us that the patient actually has Crohn's disease, or are we depending on a claim to designate Crohn's disease? I'm looking at this thing called the AGA's Crohn's Disease Care Pathway, and I'm wondering whether that in some way provides some assurance that patients who we are identifying as having Crohn's disease actually have Crohn's disease. Does the PRT, is this something you looked into at all?
I have to say, I think we could ask the submitters about this. My assumption was that this was an, endoscopically pathological diagnosis, and it went from there. But
we did not, as a PRT, we did not ask specifically about confirmation of diagnosis. And I looked at the AGA pathway that you're referencing, and I believe that is based on some sort of endoscopic evidence of disease, but we did not question, and nor did the proposal state that there was a definitive diagnosis up front.
Len.
So a couple questions for clarification, which is where we are now, right? So I too was intrigued with the possibility of the chronic care management fee being a simple substitute, because as an economist, I'm always looking for simple. But I guess I want to make sure that's actually applicable in this particular case, because it seemed like, doesn't the CCMF require 2 chronic conditions to be present? And did y'all think about the relationship between what I think the fee level is in the statute and what they're implementing, and the calculation that was done by the applicants on what was required for this particular ongoing PMPM?
I'll take a first stab. So we really rested, when we did that initial data request around kind of incidence of these diseases, we also looked at the comorbidities. So we felt very comfortable that given the numbers of patients, numbers of Medicare beneficiaries with these disease, with inflammatory bowel, Crohn's, or ulcerative colitis, and then looking at comorbidities, that would definitely trigger the CCM. You're absolutely right that one diagnosis alone would not obviously allow for them to get the CCM, but when we looked at the data breakdown of presence of other chronic conditions, for example, 69.1% have hypertension. So that would be a good example of kind of meeting the criteria for a CCM, that was what gave us a little bit more kind of validity that, yes, in fact. Now, a question to ask is, would a gastroenterologist take care of those 2 conditions? And certainly we can discuss that, but there were certainly enough other comorbidities to trigger a CCM. In terms of the dollars, the commercial setting in which they're doing it approximates about $600 a year. I'm going back into my, does that sound right, Paul? I was just highlighting.
So that's $50 a month.
Correct, about $600, which does approximate a CCM fee. So remember, there's a split with the beneficiary paying some of that and Medicare paying some of that. But we felt like that was, again, a very nice potential, which is why we posed that in our PRT report.
Okay, all I was getting to is it may be that you and I both would tweak the parameters of the CCFM to fit for this, and the current one might not.
It's just
if they did have, I think, $70 a month, but anyway.
Which is why we were kind of what we wanted to understand was, you know, are there currently, is this really something that a care management fee like the CCM could offer a pathway for specialists?
Okay, and to jump on Grace's point about proprietary, because it is going to cut across a lot of these, I think. And so I'm really, this is more kind of understanding how we should think about this, or maybe how y'all thought about it at this point. But if I understood your answer to Grace's question, Kavita, you talked about how sort of the really proprietary part was the analytics, was the model that actually predicted which patient needs to be pinged immediately.
Right,
and I guess the question is, when you think, and this is not so much about this proposal, but again, how we should think about these things, I wonder if we might consider something where if something if applicants want something to remain proprietary, we sort of talk about a level of revelation to CMS, and then figure out what you could share. For example, if it is data analytics and they let us know which variables go into the model, then it would not be all that secret, would it, to figure out how to use that. But if it's hiding the variables that are in the model, then clearly that's a level of non-recoverability. So I just raised the question, how should we think about what needs to be revealed to the larger population so it can be implemented program-wide without having to pay? And I don't have an answer. I just, that to me is what's triggered by this question.
Just one other comment on the proprietary aspect that intersects with, we were looking at criterion 10, health information technology. We were also thinking about just if that potentially could add, you know, infrastructure burdens, or which cross-map to other criteria. So it was also a kind of an understanding of would there be a burden to acquire such proprietary technology that almost creates an inflexibility. But except that.
Yeah, I think that, I'm sorry, I think that was the the concern around infrastructure, cost or burden if this were to be diffused more broadly.
Bruce?
My question is, I think, similar to Lynn's first question relating to payment methodology. You said a number of times, Paul, during your presentation and in your report that the PRT wasn't convinced that a new payment model is necessary to achieve the goals of this model. And although we have seen sort of in the field, it's not uncommon to see an initiation fee and then a per member per month fee in order to create financial incentives to change care. So I'm wondering, what is it about this one that makes you makes you believe that the goals could be accomplished more simply as compared to others that you've seen in the field?
Well, I think part of it was a particular outcome was focused on decreased hospitalization, decreased ER use as the primary outcomes, and that would directly be impacted by care management. So it seemed that there was sort of a closer line between a care management fee and the outcomes they were looking for, and it didn't necessarily sort of need an entire sort of new model around it.
I'll just add, you all have access to the full proposal. You know, there's, as Paul mentioned, kind of an emphasis on hospital admissions, ER visits, and then there's this kind of lovely graph that talks about, you know, how you deal with, the payment model would deal with controlling hospitalizations and cost variation through care management and patient engagement, which actually strikes back. I'm not trying to say that the CCM is a substitute, but as an example, in the current fee-for-service schedule, there are those potential payment models, which are not alternative payment models, they're part of the fee schedule, that allow for people to look at patient engagement outside of a face-to-face office visit, and to also do the kinds of things that can lead to controlling hospitalization costs and ER visits. So again, it's not as much just looking at like a landscape of payment models, it's actually thinking critically about in the current fee-for-service schedule, or even with maybe tweaks to the current fee-for-service schedule, could you accomplish the same goals as set out by the proposer of what's in the payment model? And that's what the PRT came to a decision around. You're looking at me quizzically, like.
I always look at you that way.
That's right. Generally, everybody looks at me that way, but you know, I don't take it personally. But I'm hoping I'm just trying. What we went through was trying to understand what was in this model that could not be done potentially in the current fee-for-service schedule.
No, thank you. I wasn't getting that as completely as you just explained.
Yeah, thanks. So my question sort of follows on Len and Bruce's relative to the payment methodology. I'm curious, as you've interacted with the proposer, about the link between the payment methodology, which is not only a PMPM, but also their shared savings, and the question around how does that impact behavior, because that is one of the transformative elements of these models that we're trying to evaluate. I think there's some pieces of the model that are extremely elegant, recognizing the behavioral overtone of the disease and their assessment of the patient, and then they are deploying certain resources based on the behavioral issues, not just with this disease, but clearly that's a big issue with comorbidities, and particularly in the Medicare population. So I'm curious, were you able to discern the level of behavior change that this model distributed across these different practices that they saw, besides the patient outcomes, ER utilization, hospitalizations, but what about the actual clinical delivery? How was that changed based on the payment model, shared savings? Did that get people's attention to modify their practice styles, I guess, what I'm trying to say.
You know, I think part of the struggle is, again, the experience has been primarily in the commercial population, and translating that to the Medicare or imagining how that might work. And although there were some in there, I don't think there were a huge number. And so managing patients who might potentially have quite a few comorbidities, again, trying to think through the model in that patient group was a little challenging, given that most of the experience was in the commercial population. I think that in terms of behavioral, again, I think physicians want to take better care of patients, and so it does decrease. I think the effective part is having a care manager there and being proactive with this commercial patient population, younger population. What does work? I mean, it does, keep them out of the ER and keep them out of the hospital. So I think even if you don't get to the financial part, you get to does this take better care of patients in the younger inflammatory bowel disease group? I think their pilots have been effective for those who are interactive, the pingers, the ones who respond. But, their data also shows those who that don't respond, the results haven't been as good. And so how do we translate that or understand how that might work in a Medicare population where we don't have as much, where the model doesn't have as much experience? So I think even from does it change behavior, I think, again, you can see better care in that younger population in terms of managing them, being proactive. I think that's all good. And then there is the potential on the shared savings, although how exactly that's all distributed, I think it wasn't as clear in terms of who was going to get exactly what in terms of the money.
And just to add, and we have this in our report, but there's so many moving parts. Paul mentioned the interest, 20 large GI practices that have implemented the platform, very limited in the numbers. Again, it's a commercial population of which there was a very small handful of people over the age of 65 that were a part of it. So kind of limited in understanding what the scale could be for the Medicare population. But we do know from their commercial experience that there was an average, that there would be a savings of approximately $1,000 per patient per year, of which that would get shared potentially. And the question is, again, if it's a smaller population, when thinking about the Medicare population that have this incidence and prevalence, and the savings of approximately 1,000, which no matter how you do the shared savings, you could almost, you could ask the question, is that going to have enough financial impact to get to what you're asking around behavior change? In the proposal itself, there is not enough of a runway of experience to say, there was not a mention of here's the definitive practice changes we've seen. We did receive 28 letters of support. Dr. Kaczynski probably knows it. We read through many letters of support that talk about the excitement around this. And what we were trying to do is understand what would that, going back to our criteria, how does that translate to scale and scope? And would that $1,000 of savings per year be enough to change practice behavior as well, which is why we ultimately decided that it did not meet that criteria on that value over volume comment and secretary criterion.
Thank you. Tim?
Thanks to the PRT for all the work on this, helping us understand this. I hoped you might elaborate on one point that was made, which was that the PRT was concerned that the individual providers do not receive shared savings based on patient satisfaction and care outcomes measures. And I just wondered, since that was a little cryptic, if you could explain a little bit more about what you were thinking.
So right now, the shared savings, the kind of, in the proposal, there was no comment about linking of the kind of potential in shared savings or even the monthly payments. None of that was linked in any way to the proposed quality metrics or to any outcomes measures. So the question and the concern there was, would there be any financial ties to any of the metrics such that those finances were held at risk if certain thresholds of metrics were not met? And in the current proposal, there was no linkage of those finances with those outcomes.
So just to clarify, the concern that was raised was not about a concern about a specific proposed linkage. It was a concern that there was no
linkage. Correct.
Okay, thank you.
Elizabeth?
Thank you. One of our key criteria is scalability, and I think that includes adoption by multi-payers, CMS and other commercial payers. And I'm wondering, I'm curious about not only the interoperability of the technology, which you shared concerns about, but the interoperability of the model, as it were. So could this be integrated with other care management models across populations if it were to be expanded? Or did you explore that?
I don't think we explored that. I mean, I think it potentially would have the ability to have some interoperability across. Again, I think a lot of our well, not a lot, but a certain amount of our discussion was particularly around the Medicare population, which is what this was being, which we were focused on, and as I said before, I think their experience in the commercial has been positive and very favorable. So in terms of multi-payer, I actually feel more comfortable on how this might work in the commercial, and where I feel like the PRT had our most concerns was the lack of sort of data around how this works in the Medicare population and if it can work in that population.
I'll just add for reference, on page 9 of their original proposal, the submitters did a nice job of laying out kind of what a commercial payer would supply and kind of what the practice has to do. So to that end, we did talk about how, because of their commercial experience, they thought through very clearly kind of what structural components need to occur to have another payer, multi-payer kind of approaches. But to your question about what from a care, how could this interdigitate potentially with other care management programs, we did not discuss that.
Okay. Bob?
Yeah, I just want to make sure I understand the shared savings, shared risk model. Is it a total cost of care approach for patients with Crohn's disease, that there's a sort of a norm for spending, and if they come in, regardless of what the spending is attributed to, whether it's the Crohn's disease or any number of other conditions, they would get savings if it came in under that that norm, et cetera? And it's not a targeted savings to Crohn's disease, it's total cost of care, is it? Do I read that correctly?
Yeah, we asked the submitters specifically that, because in our initial read, it was not clear to us, and the submitters said that it's for total cost of care, and not just for the costs around inflammatory bowel disease.
Tim?
So with regard to criterion 8, patient choice, the PRT noted that there wasn't a lot of evidence around the effectiveness of the choices that would be made available. And I wondered if you had a discussion on the PRT about where we as evaluators should set the bar on that particular issue. Because one could make the argument, I think, that you can make choices available to the patients, whether or not they avail themselves of those choices is in any population is going to be variable. But isn't it the job of the people making the proposal and implementing just to make the choices available? Do they have to go the extra step and say that patients actually have to make use of those choices, which gets back to my, that's a pretty high bar for as a requirement.
Yeah, I think that's a good question, Tim, and I think we talked about it, and when you look at the more expanded description of choice, it talks about potentially how demographics of the patient population and social determinants of care are addressed. And that's a pretty high bar, right, as opposed to, because they obviously give you a menu in here of options on how to interact. And so I think we struggled with, where to set that bar. And again, we sort of set it at, we felt that, I recognize that they are providing some choice, but that we would have liked to have seen data, particularly around the Medicare population, as to what they were choosing and, how that, and I'm just not sure that it's there only because of the small number of patients. So it would have been helpful to have some experience to make some judgment about that. But to your sort of broader question, I think we will struggle with that as we, look at these PRTs.
So next steps, we're going to invite the submitter to the table. Please. Could you, as you get situated, if you could please introduce yourselves, that would be helpful. Thank you.
I'll begin. I'm Larry Kaczynski. I'm a gastroenterologist in Chicago, one of the managing partners of the Illinois Gastroenterology Group, which is one of the co-presenters. And I also started Sonar MD as an offshoot of this project. I sit on the governing board of the American Gastroenterological Association, and I chaired both the Crohn's and ulcerative colitis care pathway task forces that were published in Gastroenterology in 2014. So anything you need to know about those pathways, I'll be happy to share. I also sit on the governing board of one of the advocate hospitals in Chicago. Bridget.
Good afternoon, everyone. My name is Bridget Gibbons, and I serve as the Chief Operating Officer for Sonar MD. Thank you for being here.
Please.
Okay. Good afternoon, members of the PTAC. And first of all, I'd like to thank you all for the opportunity for allowing us to address the comments and conclusions of the PRT. It's obvious from the report that the team did spend quite a bit of time reviewing our proposal. We do appreciate that, but seem to have been in need of further information that we either didn't provide or could have provided more clearly. As a result, they were not able to give us a favorable determination. We welcome this opportunity to provide some further information on Project Sonar, which will hopefully allow the full committee to appreciate the value of our proposition. It's our hope that the full PTAC will approve Project Sonar for at least a limited scale testing of the proposed payment model. A full response to all the concerns of the PRT was sent to the PTAC members last week. I will only hit some of the key points here in my short 10-minute discussion. Project Sonar has been a passion of mine for 5 years. And I always open my presentations on Sonar with a picture of the ocean, with myself standing in front looking out at the ocean. My chronic disease patients are submarines. They're submerged. They're out there. They're running silent and running deep. They only come up if they're in trouble, which means two things have to happen. First, they have to recognize they're in trouble. And secondly, they have to realize that they can't fix it themselves. Unfortunately, they make mistakes in both of those. Ultimately, we have to bring them into port. We have to put them in the hospital. But it's not just a hospitalization. It's a bowel obstruction. It's an ileostomy. It's a fistula. It's an abscess. It's something bad happening to a patient. If you just ask them how they're doing, they'll tell you they feel fine. They always feel fine. But it's only with the return of structured data on a regular basis where we can actually impact some change. In the research that led to our project, Blue Cross Blue Shield Illinois provided us data on 21,000 commercial patients with Crohn's. And the most startling feature of that entire review was that less than a third of the patients who went into a hospital for one of these horrible complications had any contact with their provider in the 30 days before their hospital admission. We interviewed those patients, and what we heard back from them was overwhelmingly that they were going over the cliff without realizing it. On the basis of this, we decided that we needed a patient hovering system, a Sonar system, a way that we could ping the patients in between their face-to-face visits so that we could bring back structured data to the healthcare team, to the professional team. Not just an app that a patient can record their symptoms on, but something that interacts with the caregivers. This led to Project Sonar, which in 2014 became the first intensive medical home that Blue Cross Blue Shield Illinois had ever entered into with a specialty group. And even though they have discontinued their primary care intensive medical home project, they've continued the specialty one. We've been in operation for 2 years. And the 50 doctors in the Illinois Gastroenterology Group have had a very significant impact on the patients. Most recently, the pingers are showing a $6,000 per year decrease in cost as compared to non-pingers in a disease process that costs $24,000 a year. So on the basis of the success we had in IGG, Blue Cross Blue Shield Illinois has engaged us to implement Project Sonar across the gastroenterology practices in Illinois. And we've begun this process. Bridget has implemented 5 so far this year. Our success has also resulted in other non-Illinois Blues plans coming into participation, both in Minnesota and in New Jersey. But in states where no intensive medical home program exists, there are an additional 20 GI practices that involve over 600 physicians that are using the Sonar platform. These practices are participating even though they are not yet receiving any IMH funds. There's a hunger amongst the physicians out there to be part of the value-based transition. As far as the specific issues that the PRT raised with us, to me they fall into 3 main categories. Number 1, limited scope of our project. We heard that clearly. Number 2, lack of adequate quality measures that drive changes in reimbursement, and I think we can clarify that. And a lack of need of change in payment methodology. As far as limited scope is concerned, we agree with the PRT that Crohn's disease only represents a small fraction of the current Medicare fee-for-service population. But these are high-cost, high-risk, high-variability patients, and their costs are 2.5 times their percentage of the population. Ulcerative colitis, very similar to Crohn's disease in its cost, its morbidity and mortality. And this is a growing population. Even in the data that was accompanied the PRT review, there was an 8% increase in incidence from 2012 to 2015. And most studies today show that by 2025, there will be 2.2 million Americans with Crohn's or ulcerative colitis in the United States. And that should correlate to about 2% of Medicare's fee-for-service budget. So although our original study group only was limited to IBD, we are confident, though, that the patient characteristics that have been the driving force behind our new care model are not specific to IBD, but are typical of most patients who deal with chronic disease on a regular basis. Accordingly, we've moved beyond IBD and now are engaged in multiple non-IBD projects, the first of which is cirrhosis complicated by hepatic encephalopathy. 37% of the patients discharged with a diagnosis of cirrhosis have a readmission within 30 days. And 46,000 patients in the 4 categories of the CMS core measures have a comorbidity of cirrhosis. So we have initiated a study using the Sonar platform for patients with cirrhosis, focusing on the immediate 30-day post-hospitalization period where the patients will be pinged on a daily basis, either they or their designated surrogate because they may be encephalopathic. Although our practices to date have been GI-based, there is no reason why this same platform cannot be implemented in any practice type, specialist or primary care. Under the request of Blue Cross Blue Shield Illinois, we've initiated investigation of a project in type 2 diabetes, focusing on periods of high hemoglobin A1C levels, which are associated with high intensity of services. This project will be deployed in primary care groups in our service area. The PRT is correct that the experience of Project Sonar has been in a specialty-based intensive medical home. We did not mean to exclude primary care doctors, but conditions like IBD are predominantly managed by specialists. We welcome the use of Project Sonar in primary care practices and equally welcome the integration of the platform across the primary specialist interface. Sonar MD platform is a web-based platform that can be used concurrently by multiple providers at the same time. We believe that the deployment of the Sonar platform across all practices will allow more of the care to be pushed to the highest level, the lowest level licensed provider capable of providing that service and build efficiencies into the system. We therefore believe that the scope is not limited and actually can be applied in multiple disease processes and across most practice settings. Number two was lack of adequate quality measures that drive reimbursement. Most metrics available today are process measures that are not directly associated with clinical outcomes. Since Blue Cross Blue Shield provides us with quarterly, now monthly claims data on our patients, we've used this data to scientifically identify quantifiable metrics that are clearly associated with favorable outcomes. The albumin example that we included in our PTAC proposal was just one example of this endeavor. Early in our development, we performed linear regressions on 26 risk metrics that were contained in the Crohn's disease care pathway. So we linearly regressed the cost of care against each of those metrics. Serum albumin was the most powerful variable in the variation of cost. As a result, we monitor albumin quarterly. It's a simple lab test, but it has a significant difference. And we're proud to say that in our control population, the albumin slope is downward, whereas in our Sonar population, it's rising. So today, though, our most powerful metric is our average Sonar score. Even though we force our physicians to complete complex clinical decision support tools and maintain these metrics, the single most powerful driver is, can you get that symptom score down? Which means you've engaged the patients, you've applied the right therapy, and that is a single metric we've plotted, and we included this graph as a supplement in our proposal showing that over a 2-year period, they linearly parallel each other. Other metrics that we've included in addition to hospitalization rate and emergency rooms visits, appropriate use of biologic medications. Those fields don't exist in EMRs. We had to create these in the clinical decision support tool. Are they on time with their immunizations? Are they appropriately using steroids? The serum albumin I mentioned, the ping response rate, patient satisfaction surveys by outside entities, risk-adjusted average Sonar scores, and now we have implemented quarterly HADS and CDS healthy days scores because there's a 13% difference in cost in patients who are depressed at enrollment into the program. And that doesn't change so far. We have to figure out how to do that. The IMH payment received from the payer is not distributed to the physicians, but is maintained in a pool. The costs of the program are first paid for from the pool, which basically is the nurse care manager fees and the Sonar platform. And then the remainder is distributed to the physicians based upon the number of patients they're following, the average Sonar score of their patients compared to everybody else, and their patient satisfaction. No physician is eligible for a distribution of Project Sonar funds unless the CDS tool fields have been complete. The final area was lack of change in payment methodology. We are in agreement with the PRT's assessment here. Unfortunately, the current language of the complex care management codes do not allow us to participate. Number one, it's based upon minutes per month. This process does not clearly correlate with patient outcome and just imposes an unwieldy verification process on the practice. It doesn't reward practices for efficiencies that minimize staff time requirements. It requires 2 or more conditions. And I'm sorry, I'm not managing that patient's hypertension. That's the primary care doctor's responsibility. I would take it, but it's not usually one that we bear. And finally, only one practitioner can bill for a CCM code per month per diagnosis. There's no ability for us to share CCM fees across providers, which would be indicated. The Sonar platform's agnostic to the provider and can therefore be deployed in multi-condition, multi-provider settings. So in conclusion, Sonar has been a passionate pursuit of mine for 5 years, but it could not have succeeded by my efforts alone. My 50 partners in IGG have embraced the initiative and gone the full mile in its implementation. They implemented Sonar long before they received any care management reimbursement from Blue Cross Blue Shield. And thank God we found a payer who actually thought in a forward fashion to partner with us. Like in a field of dreams, though, we felt if we built it, they would come. Even now, most of the care management fee goes to cover the infrastructure necessary for Project Sonar. Very little passes to the physicians. They persist based upon a true hunger amongst physicians to be part of the solution and not to be considered part of the problem. Sonar has moved beyond IgG and has been deployed on hundreds of patients across the country, which has led to a decrease in morbidity and cost, not just hospitalizations, decreased morbidity. I was humbled by my patients' testimonials that were submitted and posted on the PTAC's public comment site. Sonar's changed patients' lives. With an approval from the PTAC and HHS, we can expand our success to other chronic diseases and across other care settings. Thank you.
Thank you both. Appreciate your comments. Thank you. We have questions now from members of the committee. Harold? I beat you to it, Harold.
Yes. I have 4 questions. The first question is, with respect to the care management process, there's been a lot of focus on the pinging. But when I read the proposal, I think there's a statement in there, at least one place, that basically says that the nurse care manager is critical to this. And at least as I sort of read what you have in here, basically you have a nurse care manager who is assessing and contacting the patients and helping the physician decide what to do with them. And the pinging technology, the sort of the smartphone technology, is a way of helping that be done more efficiently than it could be done otherwise with just home visits or telephone calls. Is that an accurate interpretation of what you're doing? And in a sense, if you had to choose one, you would keep the nurse if you had to give up the smartphone app, as opposed to saying we have a smartphone app and no nurse.
Harold, you've depicted it pretty well. But when we first initiated Project Sonar, we were using our patient portal because we didn't have a platform. And we could never get more than a 27% response rate from the patients. And so the nurses did a lot of calls. And once we've embraced the platform, for some reason, the patients, and 20% of our patients are Medicare patients, once we deployed the platform, we have over an 80% sustained patient response rate. And so what the platform does, how does it change care? This was just the beginning of the month. I get my Sonar pings on all my patients coming in through an HL7 interface into our EMR, and we can push it into any EMR. And so every month at the beginning of the month, every one of my patients' pings comes in front of my eyes. The nurse is managing it at the same time, but I see them. And so any of you who are physicians know as well as I do, when you're done with the patient, your total focus goes on to the next patient you're taking care of. But through this kind of a platform, and there's nothing really special about the platform, this could be replicated very easily by other companies and probably will. But it brings the patient back in front. And so I think you've depicted it well. But I think we're learning something.
So you found that it's made it feasible for you to do it in a way that wasn't feasible with just using a nurse and traditional technologies, but the nurse and the contact with the patient, there is personal contact with the patient, is critical. Second question is, if you have a IBD patient who has COPD or asthma or heart failure or hypertension or whatever, what do you do? Does that come up in the assessment that the nurse does of the patient whenever you're talking to the patient? And then do you actually then do any coordination or outreach to whichever physician, it may not be a primary care physician, who's managing that other condition?
If it's something where the other comorbidity directly interacts with the condition I'm taking care of, for instance, in our liver patients, if their fluid balance requires changes in their heart failure management, we have to coordinate with the primary care doctor all the time. That's a must. In inflammatory bowel disease, infections, we're immunosuppressing these patients. So I don't mean any offense, but I don't want my patients calling their primary care doctor when they spike a fever. I need to know. If I have them on a biologic, I need to know if they have a fever. But the primary care doctor also needs to know. And we can push the Sonar scores to the primary care physician, and now the patients have the ability to add notes to it for the provider, which could be passed at the same time to us and the same time to the primary care.
Okay. Third question was, there's references in the methodology to setting a target price, but there really isn't a very detailed description of how the target price gets set. And is your expectation that that is based on past average spending for the patients, then discounted by an amount that's necessary to pay for the care management, so that the fee that you're getting, so that it starts at a budget neutral level for Medicare, whoever the payer is, and then you're at risk, when you talk about being at risk for up to 5%, is it above 5% above what would be necessary to, the savings necessary to pay for the care management fee, or is it would be up to 5% above simply historical spending? How exactly would you calculate the target price?
This has been a moving target for us in this process. And at the time we submitted our initial PTAC proposal, we had never received control group data from Blue Cross, from HCSC. In January, we received that, and I did send that along with one of the responses to questions. So, scientifically, where we're going with this is this way. We know what the cost of care is for a patient who is participating in our process in the diseases we're taking care of, based upon historical information. We also know how our risk assessments can be used to better hone what that base price is, and then an add-on based upon the risk assessments that are included. The major variable, though, is we know what the platform can do to that cost of care. I mentioned that $6,000 difference. So where I envision us going with this would be that that section of money there that's developed, and the difference between pingers and non-pingers, it could be an at-risk spend. And it would be up to the practice to be able to take risk in there and know that they could provide that care for the acceptable amount. Blue Cross to date has not wanted, I don't think they want us to fail. And so it's been predominantly a one-direction risk model, but we don't get a pot of shared savings. What they do is they readjust our PMPM based upon our performance. We perform poorly, that PMPM is going to go down or go away. And if we do well, they've increased it on us a couple of times. So I think we need to use science in how we calculate where this risk pool takes us.
Fourth and final question. It sounds to me like you are tracking a lot of things about these patients. And where are you tracking those things? Is that in an electronic health record?
It's in the Sonar platform. All of the risk assessments, all the costs, the CDS tool measures are fed into the Sonar platform. We live in an era today where EMR vendors are proprietary. And asking them to change something is very, very difficult. There are a lot of companies that can catch the data and give it to CMS or give it off, but who's pitching it? Mm-hmm. We don't have enough pitchers out there, and you can't tell the major entities, I need a field that tells me why you changed the biologic on this patient. So we've built that into the Sonar
But
platform.
you said, for example, serum albumin is one of the things that you found is critical. Can you ordinarily track that in an EHR?
Yes.
Okay.
If it's electronically sent.
Sure. Okay.
If it's
but I'm just saying,
faxed,
if that's a critical thing to
Right.
track on the patients, you do it in an EHR, and it could be done in an
Yes,
EHR. Okay.
definitely.
Thank you.
Grace?
Thank you, Dr. Harold asked one of the questions, so I've just got two more. There's a lot of information about the difference between your pingers and non-pingers. One of the questions I have for you is how much you've actually dug into those two, not just as a control group in a group that's using the tool, but as something where folks either will bounce back and forth or somebody will not be inherent in the being a group, whether there's social determinants of health. Because it seems to me there might actually be a spectrum of behaviors. And as you're having to present data and get paid based upon a sort of, yes, no, what are you doing about the fact that actual patients tend to sort of be yes, no, maybe, sometimes sort of, possibly on Thursdays,
This has been the toughest question I've been faced with today so far, and it's the one we wrestle with the most. And the 13% difference in costs, we started doing depression analysis early with a PHQ-2, a very simple, and I'm not going to claim anything for that. Blue Cross asked us to do that.
Yeah, PHQ.
So, but at the end of the first year, we then filtered back and looked at how the patients did financially if they answered positively on their depression screen. And there was a 13% delta that remained 13% even after our first year. So after our first year, we said we need to address this, we need to build. So that's where the HADS and CDC Healthy Days has come in. And we're currently working with social workers to see can we impact this better. It's interesting, we send out 5 questions every month, and the middle one is a health reported quality of life question, basically a how you doing question, and they have to answer in 4 different categories. The patients who are depressed at enrollment always answered that one negatively. I feel terrible, even if their symptoms are fine. I'm not as much worried about them because they're calling us and seeking care. The bulk of the patients, even when their symptoms are deteriorating, their health reported quality of life remains favorable. They're going over the cliff. So you've touched on where I think we need to continue our focus, because somewhere along the line we have to figure out how to get everybody participating.
Yeah. I would worry about a payment system, maybe. I mean, this would be something we would have to solve, where it rewards doctors for having the good patients. And you wouldn't want a situation where somebody's not participating and there's less reimbursement or whatever, that it could have consequences if we're not figuring out some of the patient reasons that might be the case. My second question is, you made the comment that there were folks doing this that aren't getting paid right now, and you all did this without getting paid right now, and I agree with you that there's a hunger in the medical community to find solutions above and beyond the sort of traditional fee-for-service system so that we can practice the medicine that we want to practice. And I would be curious to understand a little bit about those doctors out there now that are using this platform without any reimbursement for it. That not everybody is an altruist and not everybody can afford to do that. So what percentage are doing it, and what does that imply about the sort of cost of care that aren't being paid for in the current system, and why are people actually doing this?
Well, I think that's why so many of these practices are large. They have infrastructures. They have nurses. There are so many practices out there that don't even employ a nurse. They employ MAs, and I don't mean any disrespect, but I have a slide I show that says MA does not equal RN. And so that's why the larger practices have been the ones that have migrated to us. They have the infrastructure, they have the extra internal funds, and they have more forward-thinking leadership. In Sonar, we did it for over a year without any reimbursement. I've got practice. I got one practice out in Washington State. Doctor's got over 100 Crohn's patients on. There's never received one penny, but they want change it.
But, so it's been all large practices that have been able to absorb the cost then?
Well, we do have, we have our first solo practitioner that has now wanted to be on the system, so we have both ends of the spectrum now, but it is much more skewed to the large practices, yes.
Len?
So thanks for coming. Your passion's obvious and it's contagious. That's a good thing. Makes me remember why I agreed to be on this damn committee. But anyway, let me just say, 2 questions. In the appendix, which believe it or not I did read, it's hard to, so there's a discussion of the Project Sonar math and talked about how you don't have statistical significance and you need a bigger sample. If you could, and I apologize if I missed this part, how many Medicare patients does your network have now? And how many Medicare patients would you need to get that sample where you want it to be? If we're talking about small scale kind of stuff.
We're small here.
Yeah.
We're small here. We're probably only we probably only have about 150 Medicare patients currently amongst the practices. We have had significant interest from pharma to assist us in building our patient base. We have a goal of 5,000 patients.
Yeah, okay.
And the problem comes up when you're doing multiple regressions on all these little numbers. You need more numbers.
Trust
me.
So
the selfish side of me says, I want a bigger N so that we can prove more things.
Yeah, okay, appreciate that. And so the second question has to do with this proprietary question. So you heard our exchanges before. Let me state what I think is the fear, and then, I mean, I'll just speak for myself, and I won't speak for CMS because I can't, right? But I just speak for myself. I think the fear is that if I'll just say, the analytic details are not revealed, and this thing works, and it takes off, and CMS decides to require it, then you sort of have a monopoly on what people have to buy. Okay, so really the question is, how much information can you share and still maintain your patent and all that? And second, how would you respond? Because in an economist's mind, there's always a price at which we can make this reasonable. Where's your price set now and all that?
Okay. Well, I'm very happy you brought that up. I've had a very altruistic approach at this, much to the chagrin of my business partners. And I have a big mouth and have told everybody everything, but I'm also passionate that, you know, I'm ending my term at the AGA governing board, and I've wanted to leave something. And if we look at the process whereby guidelines, measures, e-metrics are integrated into medical practice, they're thrown out there. We published these care pathways, we throw them out there. We don't know whether they actually made a difference. So where my big vision of Sonar, and it's totally not proprietary, would be that Sonar assists in bringing the data back from these initiatives and feeds it back to organizations where the people who write the guidelines can rewrite them and recraft them. Someone can replicate our platform pretty easily.
That's what I thought.
And I think we can't by ourselves create new guidelines. We can assist and become part of it. So I'm not belittling the proprietary nature, but I do have a benevolent side of this thing where I see it solving a bigger purpose. I don't know if I answered your question.
I'm not unexpectedly, Len just asked my question, so I'm going to pass. And
Okay.
go to the next.
Bob?
So I'm going to ask 3 questions. The first, the first 2 I asked before, and you can sort of educate me a little bit. So how do we know these patients have Crohn's disease or inflammatory bowel disease?
Again, another tough question. We have a series of metrics, and in IBD, you have clinical, endoscopic, pathological, serological combinations of data that provides someone a diagnosis of Crohn's or ulcerative colitis. If you have tissue, no question, you can make your diagnosis. But there are not so much, I'm going to twist your question just one little bit. It's not so much whether the diagnosis was correct, but is the risk level assessed appropriately, and should that patient be on a biologic that you're making money in your office or your HOPD for? And so I think we need to use science everywhere we possibly can, and although medicine is an art and a science, we need to push it as much to science as we can.
So, but basically the trigger is a clinical diagnosis, I mean, is an ICD code.
Yes, and in fact, our patients that were attributed to us by Blue Cross were our patients that had seen us for at least a year and had a diagnosis based upon ICD. It was 9 at first, and now ICD-10 codes, and that's how Blue Cross attributed, and they eliminated anybody who was in another shared savings program of any kind. And so the only ones that have been attributed to us are our own patients that we've been consistent with, that have been part of Blue Cross and that have those ICDs.
Okay. The second one does go to what sounds like a total cost of care calculation. So I just looked at the table that staff prepared that's on the website. In patients with Crohn's disease, 16% have chronic heart failure, 28% have chronic renal disease, 19% have COPD, 26% diabetes, 30% ischemic heart disease. They claim that 40% have rheumatoid disease. I assume that's arthritis.
Arthritis from the IBD.
Yeah, well, okay. But my question then would be, isn't the spending for Crohn's disease relatively trivial for in the Medicare population with those kinds of comorbidities, and isn't it sort of random whether you save money or don't save money?
You know, you have me at a little disadvantage here because I only have access to the commercial data that I've been provided through my payer. I can tell you in our commercial group, and our average age is in like 45. So we do have older patients with comorbidities. We initially were trying to only track our Crohn's-related costs. So I went through this elaborate assessment of any ICD that could possibly be related to inflammatory bowel disease, even to the point of uveitis and certain skin diseases. And we tracked about 2/3 of the costs were Crohn's-related. And this has persisted to a point where it's remained fairly stable. So now we don't go through that exercise. We take the total cost of care, and that's what we've been measuring. But in our population, it's about 2/3 of the cost.
In your total population?
Total population.
Okay. And so then this is, the last question goes to sort of my experience, which is somewhat dated right now, would be that Crohn's has a tendency to burn out in older age. Is this largely a disease of, I mean, the kinds of acute problems that lead to surgery and develop fistulas and all of those complications, does it happen in 80-year-olds?
I have used the same words with my patients to make them feel better that it burns out as they get older. But what actually happens in inflammatory bowel disease, the inflammatory years are the younger years. The fibrotic years are the older years. And the disease doesn't go away or actually burn out. It converts into a chronic fibrotic state. So you get obstructions, ischemia, you get ischemic issues, you get different things in the older population than you do in the younger. But you are totally correct. The aggressive inflammatory phase is younger.
So I guess the follow-up to that is, can you actually then head off those fibrotic changes through pinging and that kind of thing? In other words, are those more inevitable rather than an early intervention to prevent?
The goal in IBD is very similar to rheumatoid arthritis in that as controlling the inflammatory state, you will avoid the long-term fibrotic state. And the answer is yes. If we can treat these patients earlier.
But that's my point.
Yeah.
If that's the younger population,
yes.
What can you do with a 75-year-old who's already been through the inflammatory stage? What does the intervention accomplish?
We're in the nascent phase of anti-fibrotic medications these days, but it's tougher. You're correct.
Elizabeth?
Thank you. I'm curious about the payment model. You've said that this is being done on fee-for-service or not at all. People are just doing it. What would the optimal payment model be from your view? And are the barriers operational, or could you do something different or better in your view if it were prospective or some other payment methodology?
A couple things. My first goal in the payment methodology is to move physicians away from one patient at a time making widgets to a focus on taking care of an entire population of patients and being rewarded for an outcome. Right now, we're not. So to move physicians to that state takes some money. It takes some investment. It takes some leadership, practice redesign, and so there has to be an investment, and that, to me, the investment is the PMPM payment. We can call it a CCM payment, fix the CCM payments, and they're the same as our S codes that we're using with Blue Cross now. But there can't be an open end on this. You can't say, well, you're going to get X number of dollars PMPM. No, there has to be a measurement. What was the ROI for that? I know with Blue Cross right now, they're touting a very high ROI when they look at the $600 that they spend extra per year and the $6,000 savings they're getting on that population. So to me, the appropriate thing is an investment in a payment model followed by a risk-based adjustment going forward in that payment so that it perpetuates itself and perpetuates the physicians to do what we want them to do.
Kavita?
Thank you. I just wanted to comment how great it was to receive the proposal and understand your passion behind it. So, but I had a question because your comment about the albumin, the serum albumin, just raised something. Since it's such a significant kind of metric for you, as you mentioned, is there any conversation, or has it been part of maybe potential conversations with your commercial payers about having a downside financial adjustment if that albumin is not reflected? So I'm asking if they do not see that improvement, is there any penalty, so to speak?
Well, we've done this internally. The payer, as I said earlier, I don't think Blue Cross Illinois wants us to fail. And our numbers are just not high enough for them to be hitting us with too much downside risk yet. But we're doing it internally.
No, there is no in general, there is no downside risk at all right now based on.
Well, your monthly payment would go down.
Adjust, but not based on, it's based on that total cost,
Right.
biologic use, and just again, it's, nothing else is factored into that.
Blue Cross's major concern is financial.
Okay.
Grace?
We've been talking commercial and we've been talking Medicare, but there's a lot of younger people who don't have commercial insurance. They have something called Medicaid. I hear there's a lot of that in Illinois. Do you have any data on the non-Blue Cross population? Surely you're serving that population as well, or have you been able to provide that service even if it wasn't provided with payment back, or is there any data that would allow us to think about it a little more comprehensively than just Medicare versus commercial?
I'm glad we talked about this. I had the word Medicaid in my presentation. I took it out. Two out of every 3 babies born in Illinois are born into public aid. It's a reality. And in our practice, it doesn't matter what payer you're on as to whether you get Sonar. I don't have data. I don't have total cost data on the Medicaid population. It's not been provided to us. I would love to have that, my hands on that data.
Tim?
So I want to also echo the comments that made about the work necessary to to do all this work and to go for the next step in Medicare. I think I'll just characterize the fact that you've had a fantastic demonstration in the commercial population. I think the questions here today and your answers, in addition to the proposal and all the work that's been done, suggest that there is some legitimate uncertainty in the Medicare population. And I wanted to ask if some sort of assistance were available to you for trying to answer some of these questions in the Medicare population, would you be open to that kind of assistance?
I always say yes to people giving me things. I wrote an editorial in one of the GI journals a few months ago with a colleague about high beta illnesses. I would love to know in the Medicare database, what are the high beta illnesses? And by high beta, I mean, if you take a table and you look at gastroenterology services and you have GERD, IBS, IBD, colorectal cancer in the rows, and in the columns we have number of encounters, total cost, cost per encounter, but the coefficient of variation of cost per encounter. If you look at it in IBD, colorectal cancer screening has a 0.6 rating. IBD has a 3.6 rating. I would love to know the other 3.6 illnesses out there where we can deploy this kind of a platform. I would love to be able to get data that would allow us to put some gasoline on this.
Paul?
So, yeah, I don't really have a question. I just wanted to make a comment adding on that, you know, I thank you for bringing this forward. Your passion is evident, and I think all physicians practicing whatever specialty or primary care would like to see movement in the same way. And just thank you in particular, given my role as the lead on the PRT and having been intimately involved. So I just wanted to make that comment.
Thank you.
Thanks.
Thank you.
Harold?
Last week I did the thing that doctors fear that their patients will do, which is I went digging on the internet and did a bit of a search, and I found a number of articles about, amazingly enough, inflammatory bowel disease in the elderly. Journal Crohn's and Colitis 2015, inflammatory bowel disease amongst the elderly is common with growing incidence and prevalent rates. Approximately 10 to 15% of IBD in the USA is diagnosed after the age of 60. This incident rate is conservative. American Journal of Gastroenterology, elderly IBD patients are prone to similar medical and surgical interventions as younger patients. Generally, it can be expected that once surviving an initial severe attack, a less severe disease course with fewer relapses and hospitalizations occurs in elderly patients with ulcerative colitis, but not Crohn's disease. The Crohn's and Colitis journal Inflammatory Bowel Diseases did a study that's titled Inflammatory Bowel Disease in the Elderly is Associated with Worse Outcomes. Patients older than 65 years accounted for 25% of all IBD-related hospitalizations in 2004. Older patients with IBD-related hospitalizations have substantial morbidity and higher mortality than younger patients. Is any of that inconsistent with your experience?
No.
Okay, thank you.
Thank you.
Seeing no other questions from committee members, we're going to thank you, Dr. Kaczynski,
Thank you,
for all
everybody.
of your work.
Thank you.
Appreciate you coming. Thank you.